Great. Let's start, then later on we will discuss and we will have quick view on our system. So we are online coaching company providing online coaching, online subscription, WhatsApp subscription, hard copy book, and there are a lot of things, right? We provide data flow service, mobile application. And one thing I would like to highlight, two things we are coming up with the new project. One is dental. So those your family friends preparing for dental, please let us know for any help or any assistance or guidance is required. We are here now. Our system is all set. Probably in 1 week we are ready to go with the dental DHA and all Middle East preparation. And second thing is very interesting that a lot of inquiries we are generating is the homeopath, right? So there are lots of homeopathic doctors in your group as well. So we are shortly coming up with the big module of homeopathic. So complete well organized structure, class, coaching, subscriptions. There's a way we are doing for physicians, same thing for dentist and this homeopath. So just let me know or let my team, Pallavi or anybody know, right? So as those who are newly joining, I'm Dr. Munjal, medical oncologist, Dr. Arti, Dr. Mehdi, Dr. Ankit, Shikha, and it's a big team now growing very fastly. So this is Dr. Pooja will going to coordinate you for dental, and another doctor will join soon. Probably will start. This is our hard copy book. A lot of discounted offers, data flow we provide. As I told you, the most important secret of success. I talk to thousands of doctors. What makes you the most successful and crack you the exam in first go is the mock test. Believe me, mock test. More the mock test you give, more the excellence and confidence and you get, and you really get to know where you are doing the mistake and how to improve the score. So a lot of things can be done. I'm also co-founder for EMREE Prep along with this. So keep in touch with me, and this is biggest discounted various packages going on around 60-70% discount. So just go through it. Last but not the least, we have excellent medical MCQ for all YouTube channel. So those who are like missing the lectures class last time you did not attend it, so you go on the website and look into it. You get all the this recorded video as it is, so you are missing nothing. But live class has its own advantage and excitement. So live is live, but anyway, somehow if you miss. So let's start with the very important and very many a times neglected area, ortho rheumato. So though it's simple but looks sometimes tricky, so let's see how we go. So I compiled excellent questions for that. So you are with me for almost next 90-100 minutes. So let's start with the first question. The best initial treatment for the mild to moderate this osteoarthritis of knee joint is acetaminophen, NSAIDs, corticosteroid, none of the above. How you differentiate from OA and RA and what's the radiological findings? So just take your own time and get. Yes, Dr. Anisha, why you want to go with the acetaminophen, not the NSAID or corticosteroid? You can
Because in the question they ask the best initial treatment.
wonderful. Best initial treatment they ask, right? Fair enough. So best initial treatment cannot be this NSAID.
It is the next treatment.
Fair enough. So I would like to understand when you supposed to start the NSAID as a first treatment. not the acetaminophen. So probably this is mild to moderate pain of osteoarthritis. Why you want to exactly? What are the advantage of starting the acetaminophen over the NSAID, or why not the NSAID and other things?
It is gastric friendly. Mhm.
Okay, fair enough. I would like to know. I mean, don't worry about right or wrong. I want you to think. Everyone want to think, right? Why this not? If you cultivate this practice, then any MCQ is easy for you. Fair enough. So answer is NSAID. Anybody wants to comment why not NSAID? Why? And when you supposed to use Dr. Anita this corticosteroid? When you use the corticosteroid in osteoarthritis, is there any indication or there is no apparently any indication of using the corticosteroid in osteoarthritis?
It's high. High severity. It's already high.
Yeah,
It
anyone,
was
anyone.
the maximum result 1.5.
What I understand, based on the information Ma'am Sharina told, they are diabetic, no, Siraj. They are questioning our result. They are questioning our.
Sorry, you can unmute your mic. I muted already because a lot of background noise. Sorry, you can unmute your mic, doctor. Sorry. Yes, Dr. Asia. Any comment, Dr. Asia? Asia Topala. Any comment? See,
Sir, NSAIDs because it will cause less acidity and less acidity symptoms
fine.
compared to
GH.
acetaminophen.
So that is why you use the NSAID, not the acetaminophen, because acetaminophen is more gastric friendly, more renal friendly, more this blood or platelet friendly. So you don't want to use the acetaminophen because this is mild case. It is not severe case or patient is shouting and all. It's a very difficult case, mild to moderate pain. So you cannot start the best initial treatment. They're asking initial treatment, not the best treatment. So initial treatment could be the safest one where patient can get control of the symptoms with no or minimal side effects. So here, for the sake of the answer is acetaminophen. We will not just only get to the diagnosis, but we'll dissect each and every options as well, right? That is real learning, right? So here for the answer point of view, the best initial treatment for mild to moderate is osteoarthritis is the OA knee is the acetaminophen. If does not act, then you can go for the NSAID and corticosteroid. I was asking someone that what is the difference between, I mean, what is the OA finding in X-ray? Please mute your mic, please. Lot of disturbance. If you are speaking and not interacting with me, please make your mic mute. You can speak whatever you want to speak for the discussion, no problem. Unmute. But I mean, a lot of background noise, it distract myself, right? So thank you very much. So can anyone tell me what are the X-ray findings in osteoarthritis and rheumatoid arthritis? So let me start with the osteoarthritis. If you have classical knee X-ray of osteoarthritis, what you can see in the things? What is the joint? What is the joint space? What is the osteophyte? What is the calcinosis? What happens to the fluid? What how the X-ray looks like? So can anyone describe? It is very common, one of the most commonest condition and each and everybody, right? When we go after 50, 55, our parents 110% they have osteoarthritis. It's a wear and tear, it's a aging process, right? So everybody will face this. So one of the global problem is osteoarthritis of the knee joint. So each and everything we must know, and it's a very frequently asked question in exam. So if you are not knowing, let me go to the complete crystal clear picture. This is a osteoarthritis picture, right? So this is a classical. So what you can see, normal X-ray. So joint space is normal and uniform. Here, not a normal, not a uniform. So it is narrowed. Can you see the gap here? The gap here, the distance between this and distance between this, right? So it is very minimal. So what does it mean? Narrowed. The joint space is narrowed and asymmetrical, not a symmetrical. So number one, the basic, right? So whenever you see the X-ray onwards now for the osteoarthritis, classical presentation is like they start, right? As the day goes off, right? It will increase. End of the day, it is very much, right? It's very much, right? And with the moment it worsen, right? So these are the classical features. So joint space is normal. This is normal X-ray of knee, and this is osteoarthritis knee. So narrowed, right? Articular surface is a smooth, this is irregular and eroded, right? subchondral bone, subchondral normal density, here the sclerotic or white. So you can see there, see here sclerosis, right? Sclerosis or whitening. If you see the X-ray, there is a sclerosis, right? So sclera, like remember sclerosis or white like a sclera, sclerotic, right? So if you can see clear cut, right, patch of the sclerotic areas on the things. Osteophytes are absent obviously in a normal X-ray. Osteophyte or bone sprue is present. So this is osteophyte. So osteophyte and sclerosis both are present in osteoarthritis. Subchondral cyst is cyst formation. So here the cyst formation, subchondral cyst formation, it is absent in normal. It's may be present, may not be present, but if you see it, it's osteoarthritis. Alignment is normal. Alignment is right and left. If you are driving a car, you are seeing every time at the car visit or car service, you are specifically saying, sir, please see the alignment. So what is alignment? It is a bilateral equality. So alignment is good here, may show varus or valgus deformity. So you must have seen many elderly people are they are walking like right, left, not going straight way. So these are the classical find. Joint space is narrow, articular surface is irregular, subchondral sclerosis, osteophyte present, cyst may be present, alignment is distorted. That's it. So this is classical view of the X-ray of the knee joint of osteoarthritic patients, right? So now let's jump to the how you differentiate from rheumatoid arthritis from osteoarthritis. That is also uh, important. And let me show you the very interesting things, right, for osteoarthritis versus rheumatoid arthritis. What are the excellent classical features, right, which we every time confuse ourselves? So it is absolutely uh, important for us to understand without failure. So X-ray of osteoarthritis versus X-ray of rheumatoid arthritis. That is again a question in exam. So osteoarthritis type of disease, it's a degenerative disease, degenerative wear and tear of the cartilage. So there is a cartilage. This is a joint, and there is a cartilage. So more you use the joint, more the cartilage will get damaged, and the synovial fluid is also little less because of this, and there is a narrow space, right, as we seen in the last X-ray. So degenerative disease, this is not a degenerative. It is not aging process. It's an inflammatory or autoimmune. So biggest difference between rheumatoid arthritis and osteoarthritis is the aging process. Almost in the all bones, the commonest joint is a weight bearing, that is a hip and knee. So degenerative wear and tear of the cartilage, and this is inflammatory or autoimmune disease. This is absolutely autoimmune disease, and where the primary culprit is a synovial inflammation. So inflammation within the synovial cavity, right? So this is inflammation. Wherever the joint is there, synovial fluid and cavity is there. Joint space narrowing, yes, asymmetrical, here asymmetrical, usually medial compartment first, and here the symmetrical. So biggest difference here, you can't see the joint space narrowing, here the symmetrical, because there is no joint inflammation, there is no degenerative changes in the cartilage. It is problem in the synovial inflammation. So usually something wrong in the synovial, but space is the same. So it's a bilateral equal symmetrical. Joint space narrowing, right, is yes there in the osteoarthritis, no, not in the rheumatoid arthritis. Osteophyte prominent as we seen in the last X-ray, here the absent. Osteophyte will not develop. Subchondral sclerosis means white sclera. Sclerosis is present here. The osteopenia, loss of the bone density near joint, loss of the bone density. Here increase the bone density beneath the cartilage. So it's a huge difference. Osteoarthritis, sclerosis, increase bone density. Here the bone density, loss of bone density. Subchondral cyst is common as we seen in last X-ray, may or may not be prominent. Erosion is rare. There is no erosion, marginal erosion, right, around the joint margin. Hallmark of RA is a marginal erosion. Alignment deformity, varus or valgus, so left side or in lateral or medial. Here the valgus, here the mainly valgus, not the varus. So if somebody has a varus, right, it is until proved otherwise osteoarthritis. Soft tissue swelling almost absent because it will not involve the soft tissue, it just involve the bone cartilage mainly. So there is no soft tissue involvement here. Soft tissue involvement is common. Synovitis, synovial space, synovial membrane is a soft tissue, and it is a disease of synovial inflammation. So synovium is commonly involved. Joint fusion is absent, they are not fusion. maybe occur in late stage, and distribution usually unilateral and asymmetrical. Extremely important. Unilateral. This is bilateral and symmetrical. This is unilateral, asymmetrical. So these are the absolute head-to-head comparison between osteoarthritis and rheumatoid arthritis. So by my sense, it is though very simple, but it is absolutely important for you to know how you differentiate. Our job is not just to get the answer, but we need to know each and everything, because these are the two commonest condition, right? You can see, right? So rheumatoid arthritis is almost like otherwise it is seen in female. It's an autoimmune disease. So we'll see a lot of logistics. So now let's close our answer. The best initial treatment for OA of the knee joint is what? So our answer is acetaminophen. Why? The initial management of knee osteoarthritis, first line pharmacological treatment traditionally has to be acetaminophen, especially for mild to moderate pain. And if pain persists after 1 year, 2 year, probably patient may get 1 year good relief with the acetaminophen. But after that, on acetaminophen with the maximum or full dose, 3 or 4 grams per day, they did not get improvement in the symptom. Then you switch to the NSAID. So NSAID is a second line options, especially in mild to moderate cases. And corticosteroids are reserved for moderate to severe or flare up. Not the first line, not the first line, absolutely not the first line. Corticosteroids. So whenever flare up or doesn't get control, in that case you can use it. Why you want to do the acetaminophen? Correct choice. Why? Traditionally, recommended first line treatment for mild to moderate osteoarthritis, safe for long term use. This is the biggest advantage. Safe, fewer GI, means GI ulcer, peptic ulcer, bleeding, renal acute kidney injury, AKI, acute renal failure because of NSAID, which is less here. So GI less, renal less, cardiovascular side effects compared to NSAID. Like NSAID may cause sometimes platelet this functions disorder, or may cause the bleeding, or it increases the risk of GI bleeding and all blah blah. Right, so which is very very less. So GI, renal, and cardiovascular side effects are very less compared with NSAID. So it should be used these things, right? Why not NSAID? Then again question, sir. Okay, fine. This is the advantage. Then why not? So NSAID are more effective, but not initial step, right? So when you supposed to use the NSAID, acetaminophen, or pain is moderate to severe or like progressed on the acetaminophen, the three advantage here is all three disadvantage. GI is less. Here GI is high. Here the renal is less. Here the renal impairment is high. Cardiovascular is less. Cardiovascular MI and stroke more. So this is the reason why they are put at the second line treatment. Though they are little powerful, but long term implication we also need to keep, because osteoarthritis is incurable disease. You cannot cure the osteoarthritis. You can keep under the control. So first you do the exercise, quadriceps strengthening, blah blah, acetaminophen, NSAID, steroid, right? Lots of cartilage and lot of drug available in market, and eventually in uncontrolled patient you go for total knee replacement. So that is a final treatment, right, where you supposed to change the artificial joint, right, with the in the knee you place, and total knee replacement is the treatment of choice in very advanced severe where the quality of life is hampered. At that time you have to think of this. So these are the all common treatment of this. So already we have seen it. We have seen also this, what is the advantage and disadvantage, and how the rheumatoid arthritis versus osteoarthritis. So I will see one this slide later on as well, but I want to jump to the next question. So from my side, I think it is very clear cut. If somebody has any doubt or any, I mean, opinion or advice, just spare 5-10 seconds for comment on these questions. If you are not agreed or something else in your mind, we can discuss further. Purnima, is that clear?
Sir, when
Yes.
weight reduction is comes, because this question is asked mild to moderate
Yes.
pain.
Yes. So see, this is the general treatment strategy for knee OA initial management. Think lifestyle first. Obviously, I mean, if somebody is obese, you try to lose the weight. Exercise. What exactly exercise you want to do? Quadriceps strengthening exercise. Strengthen your muscle. You cannot do anything with anything improvement in the joint or this cartilage, right? It's a aging process, right? But by strengthening the this muscle of the knee, you can reduce the morbidity of the knee joint, you can reduce the destruction, you can decrease the pain, inflammation in the knee. So exercise is very important and you should consult the physiotherapist. Avoid overuse unnecessarily, right? And medication, acetaminophen, NSAID, steroid, and then surgery like total knee replacement for severe cases. So this is what the general everybody knows, right? So let's jump to the next question, right? That is also simple one liner, but in one question we discuss a lot of questions, right? Not just one liner, but this one liner will clarify lots of concept, right? So they can ask you long scenario, but this is bottom line. 45-year asymptomatic female detected ANA, that is anti-nuclear antibody positive. What is the treatment? Interesting. NSAID, steroid, immunosuppression, no treatment, right? Why you don't want to treat? Because she is a ANA positive, so you must treat them. Yes, now your time starts now. You think over it. What do you think? I mean, I need why. If you say A, Y, B, Y, C, Y, D, Y, so my job is to ask you the why. That's it. And we'll discuss each and everything. Yes. Everybody post your answer. Probably we join now more than 25 doctors in the class now. So not a small number, 25. I'm seeing only just 2, 3 answer. Rest 25 people are not answering. So think that yes, Dr. Asia Topala, sorry for asking you question again and again, but you will never ever forget these questions in your lifetime if you discuss. Yes, Asia. So what do you think? Why you want to use the immunosuppressant? Why you don't want to use steroid? Why you don't want to use NSAID? Why you don't want to wait and watch, no treatment as patient is asymptomatic? Right. So now you tell me your answer, Dr. Asia. I usually ask the person who has given the wrong answer. Don't take it otherwise, but it's a learning.
Sir,
Yes.
because it's anti-nuclear antibody positive,
Okay.
some antibody, so immunosuppressant.
So you can't
That
use NSAID because patient is asymptomatic. See, very important and interesting task is patient is asymptomatic. So by giving the immunosuppressant, what you want to achieve the goal? What exactly you are thinking that okay, fine, I'll start early the immunosuppressant drug to this patient who is ANA positive, but absolutely fine, no pain, no fever, no inflammation, no loss of activity, right? Absolutely enjoying the life. Just she came and you did A and A is positive. Now you are worried. So why you want to treat? If I can say, don't treat this patient. Is a wait and watch. When symptoms start, you treat it. Isn't it a good option? Isn't it a good option?
yes, sir.
Wonderful. So would you like to still stick to the immunosuppressant or you want change from
No,
wanna
D.
change the answer
No
C to
treatment.
D? No treatment. So
Yes,
D. So now you switch and shift the gear from C to D, right? If I'm not wrong. Right. Yes, Aniba, why you don't want to treat this patient? ANA positive, what happens if you don't treat this patient? She will going to develop then ANA positive. She maybe have SLE and SLE nephritis and a lot of complications in the joint, in the kidney, in the lung, right? In the eyes. Why you don't want to treat Dr. Shaniba?
Sir, it's a
What is
screening test and a non-specific. Other than SLE, in other case also and may be positive, but this case the patient is asymptomatic.
okay,
So
so patient, so what is the main reason of not treating this patient in spite of having ANA positive?
it's
Why you don't want
non-specific.
to treat non-specific? What do you mean by non-specific?
Like in case of SLE, if sorry, double-stranded DNA, is specific for that.
Sorry, I'm don't take it as I did not still understood what exactly
Uh,
you're trying to convey me the message. My question is, this patient is ANA positive. Why you don't want to treat? I'm worried. I'm worried. Being a patient, sir, what happens? I read the Google literature. This can cause renal failure. This can cause dermatitis. This can cause osteoarthritis. This can cause a lot of skin manifestation. This can do long list of problem and complication. Why you don't want to treat? How you convince the patient's relative or what should be your answer. Sometimes educated patient is sitting in front of you and say saying, sir, I did my wife's ANA, right? And ANA is positive and you ask a lot of question, everything is fine, she is asymptomatic, right? And patient is worried, she has a very much IT internet savvy guy, using a lot of chat GPT, and he's scared of complication of ANA positive. You got my
Sir,
answer
I don't.
question. Anyone wants to have any comment?
Well, immunosuppressants has side effects of its own. So why to start when the flaring up is not present yet?
Fair
So
enough.
maybe
So
we can
immunosuppressant we don't want to use by your advice and expertise.
immunosuppressant or even
And
steroids. Yeah,
even steroid you don't want to use. Then why you don't want to use NSAID?
NSAIDs, the patient doesn't have any pains or any
Wonderful.
inflammation right
So
now because the
pain is
patient doesn't
not
have
there,
any pain.
inflammation doesn't require. So let
Yeah,
me tell you, the answer is this: there is no treatment for ANA positive, but one most important thing is asymptomatic. Asymptomatic is most important thing. Let me tell you, if you do the routine population, if you screen 100,000 patient, 1 lakh patient, right? Few patients may have ANA positive. In general population, who is absolutely asymptomatic, if somebody does my ANA out of 100,000 patient, they are doing the screening program in my society to 100,000 people, right? And suppose I get ANA positive, and doctor is calling me, sir, you have ANA positive. I don't have any symptoms, sir. It was just routine screening. Came to my society. I said, give the sample. I don't have any problem. No need to treat. Treating early ANA positive, and it is present in a normal person in few percentage. Normal person even it's present where there is a no disease. So why you want to treat the normal person who is absolutely asymptomatic? So answer is no treatment for these things. Now let me ask you the three questions. What is the screening test for SLE? What is the screening test for SLE? What is the confirmatory or most sensitive and specific? Both our answer is different. My each and every question is pertaining to in context with the directly exam. So if somebody asks you now switch your gear from ANA to SLE. If I ask you what is the screening test of SLE, what is the confirmatory or most sensitive and specific for SLE? Now your start answer.
Sir, screening is NA and the
Is
confirmatory
ANA,
test
wonderful. ANA, that is anti-nuclear antibody. Fine.
and
What is the
confirmatory
confirmatory?
is double-stranded DNA.
Double stranded DNA.
dsDNA, dsDNA, right? What
Then
anti-dsDNA, it's
specific
antibodies, anti-DNA. Yes.
anti-double-stranded DNA.
Have you heard of anti-SM?
Yes, sir.
anti-Smith,
Anti-smooth
anti-Smith.
muscle specific.
Wonderful. So
No, anti-Smith.
this is the test, right? These are the tests which you need to keep in mind. We discuss lots of things in this, so we clarify all the concept related with SLE and all right away. So here, for the sake of the answer, no treatment is required for any ANA positive, especially asymptomatic patient. So this is wonderful slide. This all slide you won't get in MTB or any other Davidson Harrison. This is many from journal and all different department. I subscribe many journals, but you can take a picture. I don't mind. It's I would be happy, right? So rain, rain. What is rain? R means rheumatoid factor is rigid in the morning. Autoimmune. This is for rheumatoid arthritis. Just for your knowledge, this is also important slide along with the OA and RA. So how you differentiate? This is important, right? So I'll just little club up, or else what I can do, I'll do it later on. First, let me finish the crux of the question, right? So here, this is the question. I will discuss that part later. So our question was ANA. ANA asymptomatic, you don't need to treat. Explanation. ANA anti-nickel antibody is a screening test for autoimmune disease such as systemic lupus erythematosus, Sjogren's and scleroderma, right? So SS, systemic lupus erythematosus S, Sjogren S, scleroderma S, and this is right the things, right? So ANA positive in systemic lupus erythematosus or SLE, start from S. Sjogren, start S is a, I mean silent, Sjogren, right? And scleroderma. So these are the ANA is a screening test, right? However, ANA positive alone, especially in asymptomatic individual, does not indicate the disease. So every ANA is does not a disease, right? So you don't need to treat. A small percentage, as per the literature, up to 10 to 15% of the healthy individual, particularly middle-aged woman, can have ANA positive without any autoimmune disease. So this is beauty, right? So this is literature, right? So up to it could be 1 to 5%, but up to 10 to 20% in a randomized control trial, right? So ANA is seen in all three as Sjogren, SLE, and scleroderma. It is if it is a Positive, especially in asymptomatic, does not indicate disease, and then when there is a no disease, no need to treat the patient. And small number of patient, especially middle aged women, somewhere around 40 to 50, right, or 35 to 50, middle aged, they have ANA positive, but they don't have any autoimmune disease. You don't need to treat it, right? So management approach, no treatment. No treatment is needed for the patient who is completely asymptomatic, no clinical or laboratory evidence of autoimmune disease. So see, ANA positive with asymptomatic, no treatment. ANA positive with symptoms or symptoms of inflammations or autoimmune disease, yes, you need to treat. Yes. So clinical vignette is very important, not in this patient, most of the patients, right? So you must always keep in mind in the scenario, right? Observation and follow-up are the appropriate, right, monitor for any development of clinical symptoms. So let's take home message and summary table. ANA positive, yes, it is positive. Symptoms is there in ANA positive, no symptoms is there. When there is no treat symptoms, no need to treat, right? Patient has ANA positive, yes, ANA positive. Patient has a symptoms, yes. If they have symptoms, you have to treat the patient. That's it. So this is what the treatment is. So this is what very interesting things we need to keep in mind, because when you are in the OPD, in a physician OPD especially, you see a lot of ANA positive. Just go and ask them the question. Don't always rely on the labs and parameters and ESR and joint and space. Go. Secret of success by my 20-25 years of practice. I'm just sharing. I'm not trying to teach you. I'm sharing my own experience in hematology for more than 20 years. Whatever the patient has, whatever the report, somebody and resident and DNB comes and get to me, I'll just talk to patient. That's it. I just spend 2 minutes, 5 minutes, depends on my time. I go and talk to the patient and just do the 1 or 2 minute quick examination, pallor, icterus, lymphadenopathy, bone pains, liver, spleen, pedal edema. That's it. I make a diagnosis of leukemia, lymphoma, myeloma, aplastic anemia in just 2 minutes by observing, talking to the patients, and talking and examining the patient. So it is very important. So don't just read the paper. Don't just read the reports. Go and talk to the patient. It is really important in your practice to get the better clarity of the all patients. That's all from my side. So if anybody has any questions, I would be glad and happy to comment more on this. So by me, no treatment is required at this point of time because it is ANA negative. So no need to treatment. 10 to 15% of the patients have normal. Middle-aged women have it. Is that clear to everyone? Anyone has any doubt, question, any comment?
Clear, sir.
So I had one comment, Dr. Asia Topala. What is the patient if it is symptomatic? So yes, symptomatic you treat with corticosteroid and immunosuppressant. Answer is that, right? But asymptomatic, no. So let's jump to the next question. If you are not asking me the question, I take it granted that you understood all well from my talk, and I will go ahead, right? So if you want to ask questions, I would be glad and happy. Stop myself and discuss whatever the best possible answer I'll give you. If not asking you, then I'll go ahead. So I'll go ahead. The cause of the scleroderma. Scleroderma is a systemic sclerosis is unknown in 20% of the cases are diffuse and 80% are limited. So there are two type of things, right? One is limited and one is diffuse. So 20% are diffuse and 80% are limited. Limited scleroderma, as your knowledge, is known as a CREST syndrome. This syndrome contains calcinosis. C for calcinosis, R for Raynaud's, E for esophageal dysmotility, S for sclerodactyl. What is the T stands for in the CREST? Thrombocytopenia, telangiectasia, tracheal abnormalities, tissue hypoxia, none of the above. How you gonna differentiate from systemic sclerosis to the CREST head to head? Now your time starts. Yes, I got a few answers. Wonderful. Yeah, I'm waiting for more answers because we have 29 now, not 24, 5. Now we are close to 30 and answer is 4. I can tell the name as well. Yes, Dr. Rahib. What do you think, Dr. Rahib? What is the answer? Yes, Rahib, if you can able to speak up. Yeah, okay, fine. So fair enough. You are posting in the chat box. Fair enough. Yes, anyone? Still we are more than 20, 22 people are lacking the answer. Only 5, 6 answer I got it in the chat box. So not that difficult questions. We are knowing crest. Yes, Dr. Anisha, can you little differentiate what is a head-to-head comparison between, if I can ask you straightforward question, how you differentiate systemic sclerosis versus CREST? So answer for this question is a telangiectasia. So those who had given the B answer, it's correct. No thrombocytopenia, no tracheoesophageal, nothing. Telangiectasia is the correct answer. So amongst this CREST, calcinosis, Raynaud, esophageal dysmotility, sclerodactyl, and telangiectasia. So this is stand for CREST. CREST is the limited sclerosis, limited scleroderma. This is systemic. Systemic means all over, diffuse. So systemic sclerosis is diffuse, and this is localized or limited. So how you gonna differentiate, Dr. Saniba, from this, or Dr. Nisha? How you differentiate both the things? What antibody present
Sir,
here? What antibody? Yeah, how you differentiate? Tell me.
in systemic, there is an internal organs also involved, and
Internal organ is also involved in systemic sclerosis. So what internal organs involved?
sorry,
Liver,
in
spleen, kidney,
diffuse
brain? Yes. If you
kidney.
can be more specific of internal organs. So we have lots of internal organs. So which organ is commonly affected? Yes. Okay, fine. What is the next difference? What's the next difference? This is one difference. What's the next difference?
Antibody SCL70 and anti-centromere in case of crostitis.
Systemic sclerosis, what antibody? CREST, what antibody? Simple.
Uh,
And
anti-centromere
Centromere
and
is centromere.
SCL70.
Yeah. Everybody can speak, no problem. I am not in hurry at all. Any answer?
Centromere is a centromere antibody.
Anti-centromere is in
Anti-centromere
which?
in crust.
CREST. Anti-centromere in CREST. Okay, fine. And in SS?
Anti-SLE70. Sorry,
Anti-SCL70.
SL70.
Fair enough. So let's see the literature. Let's see the lot of things important, high yield, which probably forget, right? So what is the answer? Answer is the telangiectasia. No thrombocytopenia, no tissue oxygenation, no tracheoesophageal fistula, telangiectasia. How telangiectasia looks like, I'll show you very shortly. So CREST syndrome is the limited form of systemic sclerosis, number one, right? Limited form of. So systemic sclerosis is diffuse, limited is CREST syndrome. What is the CREST? C stands for calcinosis cutis. What do you mean, sir? What do you mean? It's a very high-fi word called calcinosis cutis. So something, calcinosis is calcium. So calcium deposit in the skin and subcutaneous tissue. That is called calcinosis, means cal means calcium, cutis means skin. So some kind of calcium is deposited in the skin or subcutaneous tissue. This is calcinosis cutis, right? Raynaud's phenomena. R for Raynaud. This is calcinosis cutis. C for calcinosis. C for cutis. So C means calcinosis cutis. Means calcium deposits in the skin or subcutaneous tissue is calcinosis cutis. If you have it, it is a CREST. Raynaud's phenomenon. Raynaud, when you have cold exposure, when you have cold weather, cold water, vasospasm of the small vessel, color changes in the fingers and toe may become a bluish. We called it as a cyanosis. So cyanosis may be the one of the manifestation of Raynaud's phenomenon. As for Raynaud, E for esophageal dysmotility. Motility is there, but it is a dysmotility, not a regular motility. Dysmotility means there is a, due to smooth muscle fibrosis, there is a dysmotility. The normal peristaltic movement is distorted. That is esophageal dysmotility. Sclerodactyl, right? So tight, sclerosis means tight, sclerosis, tight, sclerosis in the bone, osteoarthritis, right? So sclerodactyl, dactyl is polydactyl, finger or hand, sclerotic, tight, thin, thick skin over the finger causing claw-like appearance, right? Which now can cause claw hand? Another question, claw hand. I'll give you the tip. Radial nerve palsy. It's a wrist drop. A wrist drop in radial nerve palsy. Which now can cause
Median nerve.
claw-like hand? Sorry?
Median nerve.
Ulnar nerve. Wonderful. Brilliant answer. Ulnar nerve. If you have ulnar nerve palsy, you have a claw hand. If you have radial nerve palsy, radial means the wrist drop. right? And middle nerve palsy, which this is more question, right? All three questions I trying to discuss. Medial nerve palsy, what is three nerves in the hand? Radial, ulnar, median. So radial wrist drop, ulnar claw hand, medial nerve, which palsy or what exactly the finding in medial nerve palsy in the hand? Anyone, quick.
Position of thumb will be impaired.
Sorry, I'm not getting you.
Position of thumb will be impaired in case of
Yeah,
median.
position of the thumb is like fair enough. So that is one of the thing is right. And ape like a wrist, ape like you have seen the monkey wrist. It's a ape like wrist, right? Fine. So this is all. So I just get to know by claw. So I remember the another three MCQ I discussed. Right. So sclerodactyl, calcinosis cutis, Raynaud, esophageal dysmotility, sclerodactyl. Sclero means tight or thick, right? And claw-like appearance and telangiectasia. So here the answer is telangiectasia. So you must know what is the content of the crest. So T stands for telangiectasis, dilated small blood vessel, especially on the face, on the hand, and mucous membrane. Right. So telangiectasia is there. So crest, this is the crest syndrome. Crest is a limited systemic sclerosis. Diffuse is a systemic sclerosis. Now let's see what and how this all antibodies and all how it works and sorry, this is question. This is yes. So this is very interesting, right? And take home message for you guys, right? I try to put it in a very simple one slider to avoid lots of pages and pages reading. So crest means centromere. Crest means calcinosis cutis, Raynaud, esophageal dysmotility, sclerodactyl, telangiectasia. So crest means centromere, right? Crest means centromere, limited limited cutaneous because its crest is a limited systemic sclerosis. If somebody asks you which has the best prognosis, so obviously limited has a best prognosis, diffuse all over the body has a bad prognosis, right? So crest is a good compared with the scleroderma. Here the centromere, anti-centromere antibody is present here, and here scleroderma or diffuse systemic sclerosis, right? Scleroderma SCL 70 SCL. So S for SCL, simple to remember. C means crest, C means centromere, S scleroderma means S starts from N. So all antibody, crest, centromere, scleroderma, SCL70. Is that clear to everyone? Yes or no? So prognosis is good and bad, right? So let's last before closing the questions, quick comparison table. Limited, that is crest, diffuse, that is diffuse or systemic sclerosis, SS. Here the C for crest, anti-centromere, S for S. Here the anti-SCL, or you can see anti-topoisomer is one. Skin involvement, distal to elbow or knee, proximal plus trunk. So here the proximal, here the distal. Pulmonary hypertension, extremely important. I've seen very few patients of crest in my practice, very few because they usually go to rheumatologist, not the hematologist, right? But sometimes they present the diagnosis difficult, so they think something going wrong hematologically, but eventually they turn it to be systemic sclerosis. So organ involvement is what? Pulmonary hypertension. Here pulmonary, but not the hypertension. Two important thing: fibrosis and renal crisis. So lung fibrosis, not the hypertension. So if somebody asking you, patient develop pulmonary hypertension, what could be the diagnosis? Right, crest or systemic sclerosis? Answer is crest, right? Pulmonary hypertension. Here the pulmonary fibrosis. And prognosis, as I told you, it is a limited disease, so the prognosis is good. Here the prognosis is bad. So I think now it's very crystal clear, and comparing all the things is extremely important for your knowledge. So you don't need to just mug up the question in answer. You need to understand the whole physiology, pathology, antibody, X-ray finding, MRI finding, initial test, best sensitive, specific test, and last but not the least, the treatment as well. So this is what the picture, very interesting picture. I got it from one of the searching. Calcinosis, right? So here you can see skin calcinosis means calcium deposited in a skin or subcutaneous tissue. So this is classical calcinosis. Raynaud's, you know, Raynaud's, all the tips of the fingers, vasospasm, they become blue, usually blue in advanced cases like cyanosis because of lack of blood supply, vasospasm. right? Esophageal dysmotility, sclerodactyl. So this is sclerodactyl, sclerosis, thickening of the finger, right? And telangiectasia. So this is dilated tortuous veins or vessels usually seen in the skin or mucous membrane. So these all are the features of CREST syndrome. That's it. Any questions, Dr. Saniba? You got the question, you got the answer, you got the concept.
Yes, sir.
Wonderful. So homework from my side. Always ready for the homework. Those who are joining me first time, there are triad. This is triad. I love this triad for MCQ. If you want to become a master of any MCQ, cultivate the practice. Ask yourself what is the diagnosis, how you gonna investigate, and how you gonna treat it. So they ask 95% of the questions in the exam, whatever you give DHA, HAD, MOH or QCHP, Oman. They either ask the diagnosis, they either ask the investigation, they either ask the treatment, right? So you need to practice from now onwards. In every MCQ you need to ask three questions to yourself. What is the diagnosis of this scenario? How you supposed to investigate this scenario? And if it is all treatment, say for example I ask you what is the treatment of CREST, what is the treatment of systemic sclerosis, so you must know it. They may ask you, they may not ask you the way I'm going. I'm trying to give you the concept, not the mug up, not the ratify, right? Concept. You need to understand, right? So if you understand, you can answer any question. So always keep in mind the three questions. So let's jump to the next question. A 27-year-old man. Any question? Sorry, I'll give a 10 minute of space for any question. Sorry. If no comment, I'll proceed. Wonderful. Homework
Sir,
is to
can
go
you,
and get the treatment of sclerosis, systemic and CREST. Yes, your question. Someone is asking me.
sir, the treatment part a bit
That is homework. I
into.
already given you,
Okay,
right?
okay,
So if
sorry,
I
sir.
tell you everything, no problem. No need to
Okay,
be
okay,
sorry.
sir.
I'll give you. Otherwise, see, push yourself in uncomfortable position. If you are in comfortable position, you cannot crack the exam. If you are in uncomfortable position, you can crack. In comfort zone, you cannot crack anything. Make yourself bit uncomfortable. Try to stretch yourself. Try to do extra work. Try to read one more overtime, 1 hour for MCQs. Push yourself bit hard. 100% it is doable. 27-year-old man present with the months of back pain that is worse as night. He is diminished expansion of his chest on inhalation and flattening of the normal lumbar curvature. What is the most accurate? What is the most accurate of this test? So they are asking the test. Test means diagnosis. Again, draw. When you start any MCQ, draw this triad. Ask yourself, what is the diagnosis? So here there is no diagnosis. By my sense, there is a no diagnosis given here. So first of all, don't break this triad. So first ask your question yourself, what is the diagnosis? They are directly asking the second part, investigation. They are asking investigation. And I'll ask, if they had given diagnosis, they had given investigation, second part. I will ask you, what is the treatment of this? So we don't know anything in this scenario. Neither we know the diagnosis, nor investigation, nor treatment. So first of all, someone can tell me the diagnosis, then job would be more easy and simplified.
Sir, ankylosing spondylitis.
Spondylitis.
Wonderful, brilliant, wonderful, brilliant. Ankylosing spondylitis. So tell me, Dr. Purnima, if you want to interact with me,
Yes,
what is the
sir.
definition of ankylosing spondylitis? Which joint is
Uh,
commonly affected? And how you differentiate from osteoarthritis, rheumatoid arthritis, and ankylosing spondylitis? So give me a little bit idea about it, all these things. Yes. First of all, how you define, what is the picture in your mind about ankylosing spondylitis? How the patients entered into your OPD think in that way. I'm thinking in that way. How the leukemia comes to my office, how the ITP comes, how the lymphoma comes, how the myeloma comes. I have some picture in my mind how they comes without scenario. So what is the impression in your mind of the
it is
ankylosing spondylitis?
it is a chronic inflammatory arthritis,
Wonderful,
usually lower back, usually in the typically
wonderful,
in lower back.
wonderful. Which
It's
joint is affected? If I can ask you, do you know any name of the joint like knee joint, interphalangeal joint, cervical joint? Which joint is commonly affected?
Sir, sacroiliac joint.
Brilliant, brilliant. Sacroiliac joint. So chronic, inflammatory, back pain, sacroiliac, these all are the concept. So that is involved. Okay. Is there any blood test by you can say 100%, sir, doing this blood test, I can tell this is 100% this ankylosing spondylitis. Anyone open for all whole house, all 30, 40 people. Any blood test which 100% confirm that, sir, if it is ANA positive or blah blah positive, it is ankylosing spondylitis. Is there any blood test or no blood test?
Sir, no blood test. HLA-B27 is non-specific.
Okay, no blood test. So
Then we
excellent. So by your sense, there is no blood test. So blood test cannot diagnose the ankylosing spondylitis, isn't it? Yes or no? Fine.
yes, sir.
Then second question. Then what query? What can diagnose the ankylosing spondylitis? Is it X-ray? Is it MRI? It is HLA-B27, ESR, rheumatoid factor, what, blah blah.
MRI,
Sir,
sir.
the clinical presentation, then the MRI.
Wonderful. So first is the clinical presentation. Obviously, the patient present with this age, epidemiology, this age, this sex, right? Back pain, sacroiliac, this, that, right? Excluding osteoarthritis, excluding rheumatoid, right? What amongst this test, which test you would like to do to confirm that? Okay, fine. So this is most likely MRI or HLA-D20. If presence of HLA-D27 means confirm 100% it is ankylosing spondylitis. What is the test? Open for all. Don't think of someone else answer. You think your answer. Nobody will going to help you in exam. You need to write down. Yes, Ishara 10 November, right? What's your answer if you can able to speak up?
It's bamboo spine in MRI, sir.
Okay, so your answer is MRI, not HLA-B27.
No, sir. MRI.
Fine, because you posted in the chat box is HLA-B27. Fair enough, fair enough. No problem. That's fine. MRI. Anyone else want to comment on this? Anyone wants to comment on this? Yes. So let's go to the answer. So answer is MRI. Why MRI? Let's see. So MRI of the sacroiliac joint is more sensitive than X-ray. Number one, X-ray is an initial test. If they ask you initial, anybody with back pain, what I'll do initially in my OPD, right? If I'm orthopedician, I'll do the X-ray. X-ray is it shows something, I mean, conclusive, well and good. Next immediate is a MRI. So MRI is the best detecting, right? So what it can detect, right? Then X-ray detecting the edematous inflammatory changes years before an X-ray is seen in. So X-ray, right? If you have somebody as a ankylosing spondylitis initial in 2025. X-ray, if you do the X-ray, there may be normal. It takes years, maybe 2020, 26, 27, 28. After 2, 3, 4 years, there is a changes in X-ray. But MRI, you can see early, right? Detecting edematous, inflammatory changes before X-ray is seen on the ankylosing spondylitis. Here is the beauty. HLA-B27 can be present in 8% of the general population and is not necessarily confirm the diagnosis. So it can be present in a normal person up to 8%, to up to 8%. So if I screen 100,000 patient, up to 8% they may have normal like HLA, or sorry, like this ANA is positive in up to 10 to 20, 15% of the patient. Like same way HLA B27. So it does not conclude the things, right? And ESR is non-specific. It can be increased in infection, chronic anemia, inflammation, autoimmune disease, septicemia, lot of condition where ESR, so it cannot reach up to the diagnosis, right? So it's a non-specific, it's a non-specific test. Rheumatoid arthritis will be a negative, otherwise it's not a ankylosing spondylitis, it is a rheumatoid. So rheumatoid usually less commonly the sacroiliac joint is involved, back is involved, usually this proximal interphalangeal joints are involved, few times knee joint is also involved, but not the things, right? And HLA B27 as I told you. So most appropriate answer in context with this is the MRI, right? Any comment on this? I have few things more to tell, but so far for the diagnostic point of view. So this is the story. Now let's little go deep dive into the ankylosing spondylitis, because it's a very important and very not very uncommon condition in a clinical practice. Though we are not seeing being hematologists, but our orthopedician colleagues are seeing a lot of AS, right? So the patient is symptomatic and classical for ankylosing spondylitis. A seronegative, RA is negative, spondyloarthrosis seen in the young man, right? So key features, chronic, not acute, chronic low backache. Why? Sacroiliac joint is in the back. So chronic low backache worsen at night, improves with exercise. So this is a brother of RA. RA has the same thing, right? When you have morning, they have morning stiffness in the RA. As the day goes, it improves. At days goes, it improves. So 10 o'clock in the morning when they wake up, maximum pain. 3 o'clock minimum. 6 o'clock almost nil. Reverse is osteoarthritis reverse. Morning they are fresh because they did not use the joint. 3 o'clock pain is increased. 6 o'clock pain is at peak. So more you use the joint, more the pain is that, right? So here inflammatory disease, autoimmune disease. This is degenerative disease, right? So more you use the joint, more you have pain. Here, more you use the joint, inflammation will go down and improve the symptoms with the exercise. Deteriorate the symptoms with the exercise. That's it. This is key information on the things. The rest of the things, X-ray and all the blah blah antibodies all there. But still clinical, you can reach up to the things. Reduced chest expansion because of the ankylosis. Loss of the lumbar lordosis means flattening of the curvature, that should be curvature, cervical, right? Then chest and lumbar and dorsal, this is a normal curvature, right? Cervical, thoracic, lumbar and sacral. So this curvature is little gone because of joints are stiff, they are ankylosed, they are fused. So spine is like very curvature is lost, so loss of lumbar curvature, right? And sacroiliitis, sacrum joint, and sacroiliitis, sacrum and ilium. So there is inflammation of sacrum, right? So sacrum is the most you must have seen the right. So this is a symphysis pubis as we seen, right? And this is a all pelvic bone, right? You little anatomy if you can remember. So sacrum and sacroiliac joint is involved, right? So sacroiliitis. This is a classical for ankylosing spondylitis. So that's it. So this is what the thing is. And let's see the now what exactly the accuracy of diagnosis. So X-ray usefulness may shows bilateral sacroiliitis, squaring of the vertebrae, bamboo spine, bamboo. So you see the bamboo. This is bamboo tree, bamboo spine, bamboo, right? So bamboo spine. So if somebody is giving you the question bamboo spine X-ray, but unfortunately, what is the accuracy and sensitivity? Detects late changes only late. So early it is not a good base. Early based is the MRI. So MRI, why it is based? The most important thing, early changes they can detect. Here the late changes, right? So if patient is very advanced disease and you do the X-ray, it's fine. But very early stage classical symptoms, do the MRI, detects the early inflammation changes in sacroiliac joint before X-ray changes appear. Most sensitive and accurate. Most sensitive and accurate. So this is the answer. Treatment of choice. So X-ray for late stage, initial, more sensitive, specific. HLA normal in up to 8 to 10% of the patient, and it is not a diagnostic as well, right? So it is a supportive. If it is present, you can suspect, but it is not a confirmatory. ESR non-specific, it can increase in many things. It has a very low specificity. Rheumatoid arthritis negative, it helps to differentiate from RA, right? So if you are confused between this is ankylosing spondylitis or it is a rheumatoid arthritis, do the rheumatoid factor or do the anti-CCP if it is positive, RA negative, AS. That's it. Not useful in AS, right? So if it is present, it is rheumatoid, not the ankylosing spondylitis. So this is also very important table for you to know and understand what the difference between all the five. So we need to know all the five, right? These five are in the options. So we try to exclude each and everything. Why this? Why this? Not. Same thing, same exercise, same right? Same every time you need to do for your MCQ preparation every day. So once you get the diagnosis, okay, MRI is your diagnosis. Fine, fair enough, very good, wonderful, brilliant. But you must know why not X-ray, why not HLA, why not ESR, why not RF. That's it. So you need to do that practice at the time of the preparation of your MCQs. That's it. So that's all for my side. So this is a what classical of ankylosing spondylitis. The last slide for AS, very important. It is a young male, so keep in mind usually What is a rheumatoid arthritis? It is a female. 9 out of 10 is female. So this is very important differentiating point. So some young male presented with a backache until proved otherwise, it's ankylosing spondylitis. Right? No need, right? Then you do RA factor, MRI, whatever you want. But this clinical impression is extremely important. So you must remember all these things. If you remember this, you don't need to do many fancy and costly and hi-fi investigation for your patient. So somebody tomorrow morning who is a young male telling me, sir, I have a chronic pain worsen at night, and when I go for long walk in the morning, I feel better. This is better with the activity. Chest expansion is minimum because of sacroiliitis and all joint fusion. Base test is MRI. X-ray finding bamboo space serologist B HLA B27 positive. It adds to the diagnosis. It is not a confirmatory. Why? Because it is in 8 to 10%, it is present in normal, and obviously it is not a rheumatoid arthritis, so rheumatoid factor is negative. That's it. So if you remember this slide only, then 99% of your ankylosing spondylitis is clear. So for the final talk, MRI is the most accurate and sensitive test for the early detection of ankylosing spondylitis. Is that clear to everyone? Huh. Yes or no?
Sir,
Yes or no?
Yes, sir.
Yes, sir.
Wonderful, wonderful. Thank you for your feedback. Jump to the next question. Which of the following? These are the why I selected all these questions. These all are confusing. You know everything. I know you all are brilliant, but somewhere we are confusing ourselves. What is RA? What is OA? What is ankylosing spondylitis? What is systemic sclerosis? What is CRAZE? This, that. So there are a lot of confusion amongst people. I mean, right, in the practice. So I try to make it more simplified so you will not have any hassle or problem in the exam. Which of the following antibodies likely to be present in a patient with systemic lupus erythematosus? Anti-dsDNA, anti-RNP, anti-RO, anti-phospholipid antibody, or anti-ribosomal P. So take your own time. I don't want to make you in the hurry. I need one volunteer who can tell me anti-dsDNA present in which condition, anti-RNA present in which condition, anti-Rho present in which condition, anti-phospholipid present, how do they present, blah blah. So first of all, remember the triad. Triad first start with the diagnosis. So they had given the diagnosis. Diagnosis is systemic lupus erythematosus. Now they come to the want to jump to the investigation. How you supposed to investigate, or right? So following antibody likely to be present means you are doing some kind of investigation to confirm your thing. So what investigation you gonna do for this patient? Yes, yes. Only two, three comment. Yes. If you wish, I can see all the name and I'll tell the name. Yes, Dr. Indu, any comment?
Sir, anti-DS DNA is seen in SLE, sir.
Anti-DNS, anti-DS. What is
Anti-DS
D?
DNA.
Wonderful. So what is DS stands for? Is there any
Uh,
full form of DS or just DS?
Sir, double stranded.
double stranded.
Wonderful. Wonderful. So anti-DS DNA is the answer. So now the screening test for SLE, screening test for SLE is ANA, but
yes.
somebody asking you this specific test, right? The sensitive and specific, then anti-DS DNA. Now let's juggle to all the things, right? How it one from another it differentiated, where it seems where. So that would be very much clear cut in our mind from now onwards. So systemic lupus erythematosus is an autoimmune disease characterized by a wide range of antibodies. Wide range of antibodies, not a one antibody. Interesting, what is a wide range of? So let's see. Antibody, anti-DS, then DS. D means double, S means strength. Those who don't know, anti-DS, anti-double strand and DNA. So anti-double strand DNA are shortly popularly known as anti-DS DNA, right? Antibody, disease and significance. If you have anti-DS DNA positive, what is the significance? highly specific for SLE, correlate with the disease activity as well, especially in a lupus nephritis. So anti-dsDNA is highly specific for SLE, and that is what they are asking, right? They are suspecting SLE, which test, right, or which antibody? So anti-DS. What is anti-SM? SM means Smith, right? The name Smith. Highly specific for SLE, but less sensitive. It is highly specific. This is right. This is highly specific for SLE, highly specific for SLE, but less sensitive, found in just 30% of the patients. Anti-RNP, ribonucleoprotein, anti-RNP, seen in MCTD, that is mixed connective tissue disease or disorder. Anti-Ro, very important, anti-Ro, seen in SLE, especially in a neonatal lupus, right? So if somebody has a SLE mother, right, delivered a baby, you need to know neonatal lupus. What test you will do? Anti-Ro, right? And subacute cutaneous lupus also in Jograns. So two things, right? So if you have RO, right, in SLE, right, ROSLE, right, especially in a neonatal lupus, subcutaneous lupus, also seen in Jogran. Antiphospholipid, recurrent miscarriage. You must have seen, right? Recurrent miscarriage. One of the investigation is antiphospholipid. So present in antiphospholipid syndrome, which is coexisting with SLE. So if you have a patient of SLE and they present with a recurrent miscarriage history, you must do only one test, that is antiphospholipid antibody. That's it. That's it, right? So SLE with the various combination, anti-ribosomal P, seen in some SLE causes with neuropsychiatric involvement. So these are the absolutely, you need to little mug up, honestly speaking, but these are the excellent high yield points for each and every one liner, which is very difficult to get in routine books, believe me. If you find out autoimmune disease chapter, you probably not get the systematic one liner. Anti-dsDNA highly specific for SLE, anti-SM highly specific but less sensitive, anti-RNP mixed connective tissue disorder, anti-Ro, it's neonatal lupus, anti-phospholipid is with the lupus or SLE, recurrent miscarriage, right? And anti-ribosomal is neuropsychiatric involvement. That's it. So let's see little more into the SLE, which is very important. And all disease is one, entity is one, but answer, see the difference. Key diagnostic antibodies in SLE. If somebody asks you what is the screening test of SLE, answer is ANA. Now answer will completely change. What is the patient of SLE with specific test? Anti-DS and anti-Smith. So if somebody asking you screening test for SLE, it is not anti-dsDNA. For screening ANA, for specific test for, you want to confirm, okay, doing this test, it is SLE, then it is anti-dsDNA and anti-SM. If somebody asks you patient has SLE with renal disease, which test? Anti-dsDNA, again, high correlation. If someone asks you SLE associated with the neonatal, antiro-antila, and patient with a thrombosis and miscarriage, then antiphospholipid antibody. That's it. That's it. This is the crux. This is the bottom line. So you need to little mug up. You need to take a picture, or later on you can revise on our YouTube channel, right? So this is right. So they can ask you screening, one question. They can ask you specific test, second question. They can ask you with the renal involvement, third case. They can ask you neonatal lupus, miscarriage. So only in one slide, there are lots of questions in the one slide. So you need to remember, right? Specific antibody, how they present, and what is the clinical importance. So I already told you, not going much in detail of all the theories again and again. So yeah, so this is what the things I told you. So let's jump to the next question. A patient presented with the body ache, pain with anorexia. She is menopausal for the last 2 years. Lab shows low 25 OH vitamin D, low serum calcium, low phosphorus, low 24 hours urinary calcium, and increased alkaline phosphatase. X-ray of hip shows fracture of the right side. What is the diagnosis? So first of all, just don't get confused. It looks tricky question, but not that tricky as well. So here you draw in your paper every day, every morning diagnosis. So what is the diagnosis? First of all, you need to make a diagnosis and what they are asking, right? They had given you a lot of investigation. Let's dissect what investigation they had given. The patient has a body ache and pain with anorexia. She is a menopausal. So she is a female patient, right? For last 2 years, menopause is for last year. Low 25 vitamin D. So in simple language, vitamin D is low. Low serum calcium. So calcium is also low. Low phosphorus and low 24-hour urinary calcium. Low 24 hours urinary calcium and increased alkaline phosphate. So something wrong here. The alkaline phosphate. So clue is alkaline phosphate. So is it osteoporosis? Is it osteomalacia? Is it Paget disease of the bone? Is it osteogenesis imperfecta or it is chronic renal failure? So obviously not chronic renal failure. In chronic renal failure, clue is increased creatinine. So here the creatinine is not increased. So we can rule out. A lot of things can happen here. Hypo, right? There is a hypocalcemia and all, but creatinine should be high, which is not there in the scenario. So probably renal failure is gone. So now can anyone tell me how you differentiate one A, B, C, and D? Whatever your answer is, I want to know what happens to all five things in osteoporosis, what happens to all five things in osteomalacia, what happens to all five in Paget and osteogenesis imperfecta. That's it. So if you know this, you are expert. Anyone? I tried
Sir,
my
in
level best
osteo,
to say. Yes, osteoporosis. What happens? Simply,
sir,
if your answer is osteoporosis, then what
I
could
know
be there?
my answer is osteomalacia.
Okay, your answer is osteomalacia. Okay, so why not osteoporosis? Second question.
The
Convince me
investigations,
with
everything is normal in osteoporosis.
wonderful, brilliant, super brilliant. So investigation would be normal, like normal vitamin D, normal calcium, normal phosphorus. There is no increase in alkaline phosphate in osteoporosis. Fair enough. Why not Paget? What happens in Paget? What is a Paget? What is the impression for you of the Paget in your mind? How the Paget disease, epidemiology, age, sex, what age, which joint involved, how they present, how the blood test, how is the X-ray, how is the MRI, what's the treatment? Yes,
Sir,
Paget.
lytic lesions are there in on X-ray in Paget. Lytic
Lytic
lesions.
lesion, lytic lesion, lytic lesion. Okay, this is one thing. What else? Only lytic lesion? I can say
No, other
multiple
things.
myeloma. You have osteolytic
Yeah.
punched out lesion in multiple myeloma. How you differentiate?
Sir, I forgot actually in detail Paget disease.
Sorry.
I forgot about Paget disease actually.
So your homework is to go and read the Paget disease. Do some research on Paget. Not
Okay, sir.
uncommon question asked in exam. Common question. So read two things: Paget disease of bone and what we are being oncologist saying Paget nipple. Have you heard of this or Paget disease of breast or Paget nipple? Both the things very
Yes.
common. You go and read it. Is that clear to you? Yes or no?
Yes, sir.
Wonderful. So if possibly the both question comes, you will be happy in the exam. Okay, you read both question comes. So you need to know. You can't ignore.
In osteogenesis imperfecta, there is a collagen collagen 4. Uh,
So
so
what
multiple
happens? What is
fractures
the
are there.
age? What is the
In
age?
in,
Sclera. How
in
the
a
sclera
childhood,
looks like?
Blue
is
color, sir.
bluish blue color
Wonderful.
sclera.
Brilliant. Somebody told blue sclera. Wonderful. Right? Age.
I mean,
Right?
child it is.
Fine. So now let's see. This is little, we got little more clarity, little more clarity. Now we're gonna get the complete clarity. We don't need half clarity. We need a complete clarity. So let's jump to the complete clarity. So what is the complete clarity? The correct answer is osteomalacia. What is osteomalacia? First of all, we need to know. So osteo means bone and malacia. So soft bone, right? Soft bone is osteomalacia. Why soft bone? Due to defective mineralization. So don't get confused between osteomalacia and osteoporosis. Both are the different things. Osteoporosis, right? And osteoarthritis. So three word: osteoporosis, osteoarthritis, osteomalacia. So osteo is common in three. Osteoarthritis, knee joint, right? Degenerative disease, reduced space, right? Bone cyst, subchondral sclerosis, This is all osteoarthritis, right? Then osteoarthritis, osteomalacia. We are talking about osteomalacia, right? Then osteomyelitis. So you need to know, this is your homework. Go and get it. What is the head-to-head comparison between osteoarthritis, malacia, myelitis? Then you get complete clear-cut picture. And osteogenesis imperfecta. So these are the similar word. We many times confused. And one we forgot is osteoporosis. So osteoarthritis, malacia, osteomyelitis, osteogenesis imperfecta, and osteoporosis. Is that clear to everyone? Yes or no? Yes or no? Wonderful. So let's jump for the osteomalacia. What is osteomalacia? So osteomalacia is a soft bone. Why there is a soft bone? Due to the mineralization, defective, not effective, defective mineralization of osteoid matrix in the adult. So it is not a disease of childhood, adult. Most common cause of osteomalacia is vitamin D, and this is present in each and every doctor. Each and every doctor. We did in our association 50% plus doctors, qualified, well, highly educated, rich, well to do, good nutritional status have a vitamin D deficiency because they have never seen a sunlight. They never seen a sunlight. Vitamin D deficiency is the commonest cause of osteomalacia. So if you want to avoid osteomalacia, free of charge treatment before 8 o'clock, just sit 5-10 minutes in front of the sun. That's it. Rays get into the skin, that converts this to vitamin D, and presence of vitamin D will absorb the calcium from the intestine. So if you do not have the vitamin D in your body or low level, calcium will not get absorbed, which you are taking from the diet to the stomach, skin, I mean circulation, and you get a hypocalcemia, right? So when there is a hypo, vitamin D is less, it will not absorb the calcium. So obviously vitamin D is low, calcium is low, phosphorus is low, urinary calcium low, low plasma, low urine, right? Alkaline phosphate. So only thing which increase is the alkaline phosphate, and that is our scenario. Vitamin D low. Why it is low? Decrease intake and sunlight, as I told you, absorption. So anywhere problem, the biggest problem is the sunlight. Believe me, everybody is eating well. Absorption is fine. We don't have any intestinal disorder, Crohn's disease, ulcerative colitis, irritable bowel syndrome. We are fine. Absolutely, absorption is not problem, right? There is no celiac sprue. There is no atrophy of the villi in the intestine. Everything is fine. But sun is a problem, major problem. Out of these three is we are taking good diet. Our absorption is good, but we are not getting sunlight. So go and get the sunlight if you are vitamin D deficient, right? So this is low, right? Calcium, reduced intestinal absorption. I told you, due to low vitamin D, the job of the vitamin D is to absorb the calcium. So if you have low, this is low. Decreased phosphorus reabsorption. So because of vitamin D deficiency, your serum phosphate it not get reabsorbed, and it is that is why it is low in the serum, right? Because serum calcium is low, urinary calcium is low, and alkaline phosphatide increase osteoblastic activity and osteoclastic activity. There are two activities, osteoblast, osteoclast. Go and read what is the difference. I'll tell you next time. Homework. Osteoblastic, osteoclastic. How you differentiate head to head? What is blastic? What is clastic? Where you see the blastic? Where you see the clastic? What is the X-ray changes in plastic? What is in the clastic? So probably they may ask, but you go and read it. X-ray finding, looser zone, pseudo fracture, bone pain and fracture. And here this is classical for osteomalacia. What you see is pseudo fracture, bone pain, fracture, right? So this is what happens. Your calcium is low, phosphorus low, bones are brittle and weak, easily to. So it is a simple, free of charge treatment. Go and get the sunlight. That's it. So crux of the talk is go and get the sunlight. So what is the difference head to head? This is a beautiful slide. If you are taking picture, I would be glad. This will the most simplified. We have 5 options. One is the osteomalacia. We have seen what happens in osteomalacia. Everything is low except alkaline phosphate. So this is the picture of osteomalacia. How you differentiate from osteoporosis? So calcium is normal, phosphorus is normal, alkaline phosphatase is usually normal, right? So this is osteoporosis, aging process. Everybody will get osteoporosis, especially in a female after menopause. The estrogen, progesterone go down, both becomes very weak, and they may get the pathological fracture. So need regular exercise, vitamin D, calcium supplementation. They may need zoledronic acid or bisphosphonate to strengthen the bone and quadriceps strengthening. That's it. So these are the treatment. Paget disease. Paget disease, alkaline phosphatase is increased, but normal calcium and phosphate. In osteomalacia, alkaline phosphate ALP is not a decrease, it is increase. So reverse. So here increase, here increase. But in Paget disease, calcium and phosphorus is normal, right? While in osteomalacia, calcium and phosphorus is low. So this is absolutely wonderful differentiating picture. Here normal calcium and phosphorus differentiating picture. Osteogenesis imperfecta, it's a genesis. Something wrong with the genesis or formation. Bone formation is imperfect, not perfect. Little, I mean, the word itself says it is congenital or something related with the birth. So genetic, multiple fracture, not a single fracture, because all bones are different, right? If you have osteoporosis, broken head of femur, neck of femur, it's a one side, unilateral. This is multiple, because all bones, it's a genetic disorder, systemic disorder. So not the one fracture, multiple fracture in childhood. This is number one clue, and blue sclera, collagen, right? So this is osteogenesis imperfecta. So two things you need to know, right? Just multiple fracture and blue sclera. Chronic renal failure, it's all there, but it is secondary to either hype, right? Phosphorus is increased. If calcium is reduced, phosphorus is increased in chronic renal failure. Opposite pattern, right, in hyperparathyroidism, right, and also chronic renal failure. Obviously, the creatinine should also be high. EGFR is less than normal, or probably in a chronic renal failure less than 30 or 15, grade 3, 4, 5 renal parenchymal disease. So that also gives you the clue about. And there is a history of hypertension, history of diabetes, history of NSAID abuse. Nothing is there in the scenario. So that's it. This is what the thing is. So this is the very simplified chart. I brought it for you guys. So now let me, yes. So last but not the least, the head-to-head osteomalacia and osteoporosis, those who are confusing themselves. I'll remove the confusion. Cause is vitamin D deficiency because of sunlight, diet absorption. Probably the sunlight is most common osteomalacia. This is low bone mass. It is not vitamin D deficiency. Vitamin D is normal, but the bone mass is low because of any reason, aging, hormonal, osteoporosis. Calcium phosphorus is low as we seen. Here osteoporosis normal. Alkaline phosphatase is increased. Here normal. So in osteoporosis in general, calcium is normal, phosphorus is normal, alkaline phosphatase is normal, right? So this is normal in osteoporosis, right? So, and what test we do? We check the osteoporosis T score, right? Have you heard of the T score, right? Yes or no? T score, have you heard in osteoporosis, right?
Yes, sir.
So T score 0 to minus 1.5, more than 1.5, right? 2.5, right? So this is the T score, right? So what is osteopenia? What is osteoporosis? And another term is osteopenia. There are a lot of terms start with osteopenia. So you need to know what is osteopenia. It is a it's a it's a one stage before the osteoporosis is osteopenia, osteoporosis, and this is normal. Normal become osteopenic, and osteopenic become osteoporosis, and they are brittle bones, pathological fracture. That's it. This is what the pathology. X-ray is loser zone, and this is thin trabeculae, which you can see, right? Not usually the fracture. So osteomalacia is a vitamin D deficiency induced by osteomalacia. So vitamin D is very common. Every other individual is vitamin D deficient. So go and supplement. Simple. This is again a very interesting chart. I got it for you guys. So let's go, and then I think we can stop or take one more. Brilliant picture, brilliant, very brilliant picture. You take a picture of this and mug up. See every day, paste this picture in front of your bedroom or in front of your study room and read it every day, right? So the what is normal osteoporosis? See, all normal, normal, normal. Osteoporosis, bone mass is gone, bone loss. That's it. Nothing wrong with the vitamin D or not, with the kidney or calcium or absorption, right? It's again aging process. Osteoporosis, osteomalacia is in low calcium, low phosphorus, high alkaline phosphate. This is what our scenario is. It is because of vitamin D deficiency. Paget disease, right? Alkaline phosphatase is increased, but the differentiating point between osteomalacia and Paget is the calcium and phosphorus, which is low in osteomalacia, normal in Paget. Multiple myeloma, it is a plasma cell dyscrasia. It's my very interesting subject. We'll see it sometime in hematology. You love it. So, plasma cell dyscrasia or plasma cell disorder, where there is a plasma cell which is in the bone marrow, right? Which erode the bone. So more calcium is released in the blood. That is why hypercalcemia we see sometimes crab, calcium, renal, anemia, and bone. This is minor diagnostic parameter. Major is a plasma cell more than 10% plasma cell in blood or bone marrow, or there is a biopsy proven plasmacytoma is the diagnosis. So I made you very easy for you how you diagnose multiple myeloma. Major criteria is more than 10% of the plasma cell, right? Monoclonal plasma cell in the blood or bone marrow, or plasmacytoma on the biopsy. And minor criteria, one of them is suffice, good enough. So one major, one minor would be more than enough. Calcium, renal anemia, hypercalcemia, renal involvement, anemia, and osteolytic punched out lesion. Osteolytic punched out, classical name in the picture, osteolytic. So if it is there, it is multiple myeloma. And because of bone involvement, bone is eroded, bone is destroyed. That is why calcium is high, hypercalcemia. C for calcium, hypercalcemia, right? Also phosphorus is high, but alkaline phosphatase is normal, which is high in osteomalacia, which is high. So this is differentiating point. Bone metastasis, something spread to the bone, right? Breast cancer spread to the bone, lung cancer spread to the bone, liver cancer spread to bone, multiple myeloma to bone, in which calcium is increased, phosphorus is increased, but the alkaline phosphate is also increased. So this is only one condition where everything is increased. So calcium, phosphorus, and alkaline phosphate, all three increase. Considered some kind of bone metastasis from the primary site from the body, either liver, lung, bone, right, or renal cell carcinoma, where they more metastasized to the bone. So when there is a bone, secondary bone metastasis, commonly in female breast, lung is the common, breast and lung is very common. Hematological malignancy, it's a multiple myeloma is crab. Crab is hypercalcemia. Crab. Bone metastasis. So calcium increase, phosphorus increase, alkaline phosphate increase. Primary hyperthyroidism, hyperthyroidism, hyper. So it increase the growth hormone, increase the calcium, right? And these are the normal, usually normal, right? Calcium is increased. Two things are hypo, it's a reverse the picture, and renal failure, obviously, right? Because kidney is not concentrating, not reabsorb. So calcium is reduced, but the phosphate is increased. And alkaline phosphate could be normal increase. How you differentiate from osteomalacia? Phosphorus should be increased. It is not increased in osteomalacia, it is reduced. So this picture is completely crystal clear to differentiate one from another, and lots of questions in the one paragraph. They can ask you hundreds of questions from one paragraph. This increase, this decrease, this increase, that decrease. You don't need to confuse yourself, right? You can see how many questions: one, two, three, four, five, six, seven, eight. Eight important question in a one slide. They have, I have asked you osteomalacia. They may ask you Paget. They may ask you this. They can ask you anything. That's it. So this is what the bones and bone related problems and tricks and tips and queries. So you need to know each and everything for the exam point of view. And last but not the least, for this today's session, and then I will have a quick feedback and I close the session. The commonest nerve injury associated with humerus fracture. Humerus fracture. Somebody has a humerus fracture, radial nerve, ulnar nerve, musculocutaneous, axillary, median, blah, blah, blah. So first of all, you get to know the diagnosis. So we don't know the diagnosis, which nerve, right? And I want to know if the radial nerve injured, what happened? If ulnar nerve injured, what happened? Or this musculocutaneous, what happened? Axillary nerve, when and where happened, what happened? Median nerve, at what injury and what happens to the body? Anyone volunteer. Not a very tricky, difficult question. Basic questions, but we must know. Yes. Yes, anyone. Anyone. Yes, anyone. I did not get any answer in the chat box so far. We are even at the 1.5
Radial
hour.
nerve injury causes wrist drop.
Radial nerve injury causes wrist drop.
Wrist
And
drop.
humerus fracture causes which nerve injury?
Injury to the surgical neck of the humerus causes axillary nerve injury.
Fine. So what do you think? A, B, C, D, E. Which nerve gets commonest
Axillary
nerve
nerve.
injury?
Axillary nerve
Axillary.
gets injured in humeral fracture.
Oh, fine. Let's see what comes. This is likely an anatomy question. If you know the anatomy of humerus fracture,
Yes,
or
sir.
what is a humerus, what is a shaft, body. Anyone else? I mean, one answer is a axillary nerve is the most commonest nerve injured during the humerus fracture. Anyone, any comment? Isn't it?
Radial.
Okay, so one answer is axillary, one answer is radial. Anyone else? Anyone else? One answer is radial, one answer is axillary. Yes, Asia, any comment? Topala,
Um,
what do you think?
Median.
Okay, so three answer in the house: radial, axillary, and median. Anyone else? Now two left: ulnar and musculocutaneous. Anyone? Wonderful. So answer is a radial. A radial nerve is the most commonly injured nerve in a humeral shaft fracture because it runs spirally around the posterior surface of the humerus in the radial or spiral groove. So there is a spiral groove or radial groove. Go and read the anatomy, right? So it's a shaft of humerus, right? So shaft of the humerus, right? So humerus fracture, most commonly injured nerve is the radial nerve. Let's see anatomical correlation. Exactly. Then all answer will be clear cut. Surgical neck, part of the humerus fracture. So if the surgical part of the humerus is fractured, now commonly injured is axillary. Doctor, are you with me? Right. So when the axillary nerve injured, surgical
Surgical
neck,
neck.
if they ask, yes. Clinical feature loss of the shoulder abduction, deltoid paralysis. Because deltoid paralysis, you cannot abduct the shoulder, loss of the sensation. Also, mid shaft means spiral groove, mid shaft or spiral groove. Right. So they are asking humeral shaft. Right. So the answer is a radial mid shaft, surgical neck and then shaft. So first is neck and then shaft or body. So first above is axillary, right? Second is a radial now, mid shaft, radial R for R radial means wrist drop. So wrist drop, right? So then supracondylar region. So just above the medial epicondyle, lateral epicondyle. So medial epicondyle just above the elbow. You can say simply supracondylar median nerve. Ape hand. I told you already. Ape hand. Loss of thumb opposition is a median nerve. And ulnar means claw hand. Medial epicondyle. The nerve is going just behind. Ulnar now. Ulnar means L for L. Ulnar claw hand, radial wrist drop, axillary surgical neck, right? Median supracondylar. So that's all, right? Radial nerve injury, key signs: motor, wrist drop, radial wrist drop, inability to extend the wrist and finger, sensory loss over the dorsum of the hand, first web space, reflex loss of the tricep or brachioradialis reflex, right? And final answer is radial nerve. So most common nerve injury associated with the fracture of the humeral shaft is a radial nerve. So that's all. Thank you very much from all everyone. Right, this is what the radial nerve is. This is the axillary nerve, right? Radial nerve groove from the spiral groove, and then above the epicondyle, this nerve median, right? So this is what the thing is. This is classical picture of wrist drop. Wrist is drop, right? They cannot, right, extend because the radial nerve is damaged. And that's it. So thank you very much all for listening me coolly and calmly for last 90 minutes. I spoke with my full energy and best of my knowledge. If I did any mistake, pardon me. You can correct me. Thank you very much. And before I end up my session, I would like to have very quick feedback. How did you enjoy it? And how was your concept clarity? And how I mean how I triggered some new concept in your brain?
As usual, perfect, sir.
Thank you. But tell me what exactly you learned. I don't want to listen perfect, but nobody's perfect. I am also learning. Though I'm a hematologist, but I have a passion in coaching, so I may take good orthopedic as well. But anyway, what is a new learning for you?
I mean, the explanation was perfect, sir. Learning in the sense like when we are, dealing with the MCQs, it's not only about the answer, but the concept is getting clearer. Not only for the MCQ purpose, but also for practice.
Wonderful. So do this practice in your real practice. So when you try to think, I every day morning say tomorrow I'll going into the OPD, I ask first when patient entered into my room, I ask three questions to myself. Every patient, what is the diagnosis? What is the treatment? How are I supposed to investigate? That's it. It makes my job. That's it. Nothing critical. No need to mug up. If you ask these three questions, lots of things you will learn every day. Because when you don't know, you go open up the book, read it. Okay, fine. Next patient, you never ever repeat a mistake because you did it already. You clarified it already. Yes, Purnima, Saniba, Joanna, Anisha. Any
That your
comment?
slides of differentiating different, like for example, osteoarthritis, rheumatoid arthritis, the slides were wonderful, sir.
Thank you very much. Right. I love the pictures and slides. So I did a lot of exercise before my
Yeah, it helps
lectures,
us
probably.
to remember faster.
Good, wonderful. Yeah, absolutely, absolutely. Pictures and clarity. Discussion also brings lots of clarity in your mind. I think so. Yes, Dr. Rahib, Anisha, any comment?
Yes, sir. It was a excellent lecture, very informative and very easy to understand, and concept clear, and all the charts and pictures are very easy to understand and follow.
Wonderful. Thank you very much. Probably this would be on the air
Sir,
in some
plethora of
time.
thanks for the session. I have
Sorry,
joined
sir.
for the first time.
Yes,
Will
Rahib,
join you
you
in
joined
future
first
as well.
time.
Yeah, it
So
was my first time. I learned.
your
Yeah,
feedback does matter to me. A lot of people have heard me many times, so probably they
yeah, yeah.
knows.
Yeah.
But
have been, I have been getting an invitation since so long. Today I was free, so I joined it. I loved the lecture by you. I I learned a lot of things from you, and
wonderful. Thank
inshallah
you very
I'll
much.
join you in future as well.
No problem, sir. I am also learning, so don't worry. We all are learning
Okay, thank you.
from each other. Thank
Plethora
you,
of thanks.
Rahib. Thank
Oodles
you.
of
Yes,
thanks.
yes, yes,
Thank
yes, Nazir. Last but
Thank
not
you,
the
sir.
least. Yes. Any comment, Dr. Nazir Khan? Fine. Anyone last? Then I'll pack up my session. Anybody wants to make any comment? Fine, fine. Thank you very much once again joining me. Let's complete the next session with a little more questions. I still have interesting, very more 10, 20 questions, which almost cover all your orthopedic questions in context with the exam. In the context with the exam. So there are a lot of things, but these are all absolutely tricky and high yield, right? So I will probably finish up the second lecture of ortho rheumato in the next class. So keep in touch, stay tuned, and enjoy our YouTube channel. Request or those who did not download it or did it, you can subscribe. All the notification will automatically comes to your inbox. Thank you very much and good night.